Welcome again to the Race Dental webinar series number 17. We are closely and aggressively racking these up, and their feedback has been phenomenal. So welcome to everyone, and welcome for attending. We are coming live at you, or I am anyway, from Race Dental Laboratories head office here in Castle Hill. We've come out of lockdown, so I'm mask-free. Hip hip hooray! We are happy to be mask-free while still maintaining a safe environment for both our staff and our work as well. So I'm hoping everyone is enjoying that freedom, or down here in Sydney anyway. So today, through enormous amounts of feedback, we have brought back one of our speakers, Dr. Geof Hall, today. The feedback from what he has been given in the past has been phenomenal, and as undoubtedly his knowledge is probably the best in the country, so we do appreciate his time. Today on episode 7, extraction versus non-extraction therapy when it comes to orthodontics, aligners and splint therapy. I do ask you to hold your questions until the end, but please feel free to log those, and I'll monitor those as we track and ask those to Geof at the end of his lecture. So put your seatbelt on. We have around about 30 to 45 minutes pending question time that Geof will be talking to us today. With well over 120 registered from Australia. I can see people from Malaysia, Singapore, New Zealand, the UK. Welcome to the UK. Hong Kong and Georgia in Europe. So it's great to have you all with us today. And no further delays now as I hand you over to Geof, please.
Thanks, Matt. Thanks for your very kind introduction. And as always, it's great to be able to talk to everybody today. I'm going to present a topic which is a real favourite of mine, because I love to bust myths. And there's a lot of myths out there with regards to extraction and non-extraction therapy. So my title is The Myths of Extraction and Non-Extraction Orthodontic Therapy Revealed. So with no further ado, some of you heard me before, but I've been around for about 31 years as a specialist orthodontist. I have a passion for education of general dentists, and I founded Smile Fast and OrthoEd, etc., etc. So I'm going to come to you as an orthodontic clinician, but also hopefully as an educator as well. So as I said, I've been around about 31 years, did my training in America, initially at the University of Pennsylvania, and I personally have treated over 11,000 patients. And why I talk about being an educator, because that means I look at my patients and I look at them really carefully at the end when I present. That's where I actually learn everything. I actually learn more by lecturing than probably you do by hearing me lecture. So whilst people are coming on board, I do like to do a bit of philosophy, because people ask me all the time, why do men die younger? And this is one good reason. Another good reason, which tickles my heart a little bit, and I think this just shows you, don't be an academic, okay? Okay. So basically, in this webinar, I'm going to discuss the following topics. I'm going to have to run through it pretty quickly because there's a lot of information. How much extra arch length do you really get with every millimetre of expansion? And for those of you who haven't heard me speak, the results will stagger you, okay? What are the most effective ways of orthodontically gaining space? And is expansion with a removable appliance really skeletal expansion? And what about orthodontic arch wires to actually provide expansion? And then the question that always is asked, or the comment that's always made, but hold on a sec, extractions are going to adversely affect the profile. Well, is that true or not true? And then the other question, which has become very popular, does extraction therapy reduce the airway? And there's all these myths out there, and people are starting to believe this garbage. So let's break down these myths, okay? So the first question I'm going to ask you is, how much extra arch length do you get with every millimetre of expansion? So, because, remember, I'm an orthodontist, and by definition, we're not that bright, okay? Contrary to popular belief. So basically, when somebody's got a crowded mouth, we've got only 4 or 5 possibilities. We can either expand the arch, we can make the arch broader, we can procline, advance the incisors, make the arch broader in the sagittal plane. We can do some IPR, interproximal reduction. Obviously, we could extract teeth, and theoretically, we could distalize teeth, push teeth back. But our predominant way is expansion, proclination, and IPR. So anytime you do non-extraction therapy, what happens? You're going to get some broadening of the arch, but also the anterior teeth are going to come forwards. The more crowding you've got, the more those anterior teeth are going to come forwards. There's no such thing, Wobby. There's no such thing as as you get broadening of the arch without the anterior teeth coming forwards. Okay, so there's no such thing. You will get a combination of some broadening, but the anterior teeth are going to come forwards. Okay, now whether, I don't care how crowded, because the other issue that happens is as the front teeth come forwards, what happens? The teeth procline, and when teeth procline, the bite tends to open. So the teeth procline and the bite tends to open. And we call that in orthodontics relative intrusion. So if we go back, so even in the deepest of bites, the teeth are going to come forwards, they're going to procline, and the bite is going to open. So there are certain situations where this is good. There are other situations where that is very bad. The more crowding, the more the teeth are going to come forwards, the more the bite is going to open. Okay, so whenever we've got crowding of teeth, the teeth try to find the path of least resistance. And you can guarantee the teeth are going to come forwards. They're not miraculously going to distalize, they're going to come forwards. Okay, so more crowding, the more the teeth are going to come forwards. So for example, so when you've got different facial types, for example, you've got a patient who already has a protrusive profile. And by that, I mean, basically you drop a line from the nose to the chin and the lips should sit approximately on that line. That's the normal profile. And if the lips sit on that line, that's the indication that the dentoalveolar complex is in the right position. But there are different facial profiles out there. For example, very common, we have a bimaxillary dental protrusion, which is a misnomer, but it means that both the upper and lower arches are too far forwards, or both the upper and lower dentoalveolar complexes are too far forward. We see that a lot in the Asian patient. So can you imagine you've got a patient like this with crowding already, and you do a non-extraction approach, what will happen? The teeth are going to come further forwards, okay? That's for sure. Then you've got the patient, the opposite, who's got a retrusive profile, and where the lips are far back behind that line. We call that the E line that Ricketts described. Now, this could be caused by the incorrect use of extractions. And I say that very carefully, the incorrect use of extraction, because not all extractions do this. And this is what we're going to break down, but the incorrect use of extractions. Because back in the 1950s, there was a guy called Begg from Adelaide. And Begg basically said, yeah, this is how silly or stupid orthodontists are, in all honesty. Begg was from Adelaide, and he found a skull of an Aboriginal, one skull, and he said he saw that skull did not have any crowding. And he said to himself, why would that one skull not have crowding? And the reason being, he hypothesized, was that the Aboriginals had a very coarse diet. Now, we don't have a very coarse diet anymore, so what happens? We need to take out teeth to make up for that lack of coarseness in our diet. So all these people for 20 years had extractions done based on the skull of one Aboriginal. Can you imagine today getting a COVID vaccine based on the study of one person? That's the same, that would be the same logic. And an orthodontist did that all around the world. Okay, they took out 4 premolar teeth, the incorrect use. But there are reasons to take out teeth, and this is what we're going to talk about later on. And then there are different profiles, and I can't go into that in detail, but there are certain type of facial patterns, like we call the dolichofacial patient, who has a steep mandibular plane angle, usually a long lower facial height, they tend to have an open bite. They are more prone or more amenable to having extractions than the brachyfacial pattern, who has a very deep bite, usually a short lower facial height. These patients are far better off normally to be treated with a non-extraction approach. So a patient who has retrusive lips, and this is a cartoon, because does this happen where the lips come forward? That's what we'd love to see. But this would happen with a lot of crowding. The picture shown here, though, is somebody without crowding. So that's just a pure cartoon. The more crowding they've got, the more those teeth are going to come forwards. So once those teeth have been extracted incorrectly and we've now got a retrusive profile, we can't, it's just about impossible to bring those teeth and jaws forward without considering orthodontic surgery. But the more crowding they've got, the more that would be a great case for a non-extraction approach to move those teeth forwards and open the bite. So there are some caveats on this. If we've got a deep bite, that would be far better treated with a non-extraction approach than an extraction approach. So the ideal patient to do non-extraction is the ones where we drop a line from the nose to the chin, they've got crowding, and we can move the teeth forwards or the dentoalveolar complex forwards and give more fullness to the lips. Caveat being we want a deeper overbite so the bite doesn't open as well. The problem case is the more crowding you've got, the more these teeth are going to come forwards. And trust me, we've gone so far away from extraction therapy that we do a lot of non-extraction therapy and we make the patients too full in the profile. So we've got to be very careful in treating some patients with non-extraction approaches. In other words, not everybody should be non-extraction, contrary to popular belief that's out there, okay? So how much space do you create? Well, we've done simulations and there are actually scientific studies to prove this. But basically, for every millimetre of expansion, if we just expand the posterior segment like you would do with a expansion appliance, if we expanded it by 6 millimetres, 3 millimetres per side, we only gain 2 extra millimetres of arch length. In other words, it's a 1:3 ratio. So if you had 8 millimetres of crowding, you would have to do 24 millimetres of expansion, or 2.5 centimetres, to gain sufficient space with just expansion. You will get other space by moving the anterior teeth forwards. But if you were just doing it by pure expansion and not allowing the anterior teeth to come forward, it's a 1:3 ratio. Not very much at all, in fact. So what are the more effective ways to gain space? Well, basically what we also know is if the anterior teeth move forwards, and for every 2 millimetres of moving the teeth forwards, we get about 2.5 millimetres of space. So close to a 1:1 ratio. That's the most effective. Now, if you combine that with what we call canine expansion, it's very effective. Because for 1 millimetre of canine expansion, we actually create 3.5 millimetres of space. So the most effective way for us to gain space in orthodontics is to increase the intercanine distance, to expand the intercanine distance, and at the same time move the anterior teeth forwards. The least amount of space we get is from posterior expansion. Once again, contrary to popular belief. So a patient like this who's got severe crowding, I don't care how much crowding they've got. I don't care. They could have 25 millimetres. I can fit every tooth in the arch. The question is, can that patient allow to have all the teeth fit in the arch? In other words, if we advance all of these teeth, like we would have to, can that profile tolerate it? Can the periodontal condition tolerate it? Are we going to get more recession, etc.? So these are clinical decisions that you have to make. So it's not rocket science to fit every tooth in, because every tooth will get into the arch. That's not the problem. The question is, should that patient's profile allow every tooth to come in the arch? Should the bite allow every tooth to be in the arch? So this is how we fit teeth in. We get a bit of posterior expansion, we get anterior movement of the teeth, etc. And so in this patient here, we did our measurements. We only got 2.5 millimeters of expansion per side, but our main way of getting a lot of space was a bit of canine expansion and incisor advancement or proclination. And you can see this from the superimposition. This is how far forwards those anterior teeth have to come to align the arch. Now, once again, that's your clinical decision, should that happen for that particular patient or not. Same thing in the lower arch. If you've got crowding, what's going to happen? There'll be a little bit of posterior expansion, a little bit of intercanine expansion, but the anterior teeth are going to come forwards. And we see this time and time again. So when you start to see photos from clinicians, hey, ask them, show me the superimpositions, okay? And then we can tell exactly what happened. That's so important. And we can show this case after case, a little bit of posterior expansion, a little bit of intercanine expansion, and about the majority coming from the intercanine expansion and the incisor proclination. That's where we gain the most amount of space, okay? And so what we can do is, what we can say as a summary, proclination is the most powerful tool for creating space to resolve crowding. So a patient who has got retrusive incisors and a deep bite and flat lips, they're the best ones to treat non-extraction. It's 4 times more effective than molar expansion. The rule of thumb, 1 millimeter of proclination gives 2 millimeters of space. So expanding the canine area and proclining the anteriors is the most effective way to create space. Your question is going to be, Geoff, what about stability? What about aesthetics? Well, we've got to look at that on a case-by-case basis because we can fit every tooth in the arch. That's not the question. The question is, should they for that particular patient? Okay. And yeah, so I did all these experiments myself on a system called SureSmile, and then I went back to find out this has all been done back in the 1990s. There was a great article here by a guy called Isaacson, who was the editor of the Orthodontist, and he basically showed increasing midline arch length by incisor proclination was 4 times as effective in increasing arch perimeter as was molar expansion. In contrast, canine incisor expansion of less than 2 millimeters can increase arch perimeter by 5. That's where we're going to get the space, is in the intercanine region, not posteriorly. So the question is, do we get skeletal expansion with a removable appliance? And we see these little removable appliances, okay, and this is a pretty picture, okay, because all you're doing is pushing on teeth. Everybody says, I'm pushing on the palate. Well, dust. You're just pushing on the teeth. Now, whether or not I do it with this URA here, or I do it with braces where I'm pulling from the buccal, it's the same concept. And you've got to ask yourself, why? And I'm going to show you case after case in a minute. So, yeah, this could work if this child is probably 6 or 7 years of age. But anything over that, you need more skeletal expansion. You need to break that mid-palatal suture. And so the older they are, the harder it is to break that mid-palatal suture. So we use, anybody who's over the age of 8 would have what we call an RPE, and this is going to give you expansion, and you'll see a midline diastema open up. That's the only way that we know that we've got skeletal expansion. And for those of you who have used this removable appliance, I'll guarantee you will never ever see a midline diastema, which means all you're doing is tipping out the crowns of the teeth. And what we do know is when crowns are tipped out, they always want to go back later on to where their roots are positioned. So they're very unstable. This is why my practice, my go-to appliance is a rapid palatal expansion appliance. And that's where I get as much skeletal expansion as possible. Because the difference here is with rapid expansion, your skeletal changes are far greater than with slow expansion. And that's been documented. And you will see that when you take your x-rays, whatever type of x-ray, you want to see the mid-palatal suture open up And when you use your rapid palatal expansion appliance, you leave it in there for at least 90 days after you've completed the expansion to allow time for that bone in the mid-palatal suture to form and solidify. So we can see when we do that, you'll see a midline diastema open up. I can guarantee you, if you don't see that midline diastema open up, you haven't got true skeletal expansion. So that's the type of midline diastema that we would like to see. That shows me that I've expanded the palate. Okay, I've expanded the palate, and that midline diastema will close up. Okay, but it's got to open up in the first place to know that you've been successful. And yeah, everybody tells me I need an expansion appliance. I need an expansion appliance to get the right arch form. Well, yeah, that's garbage. Because let's have a look at this. Okay, so we've got these patients, and we're just putting arch wires in. Because what do arch wires do? They move the teeth, and the bone comes with it. So every time you put an arch wire in, you change the arch form. And we can show you case after case. I'm just going to demonstrate some of these. Beautiful results done orthodontically. But let's have a look at it. Look at the difference in the arch form just by putting braces on. All I'm doing is pulling the teeth apart. I haven't got an expansion appliance in there because it's no different. I'm just moving the teeth, and as I move the teeth, it deposits bone. So that's the upper arch. What about the lower arch? Same thing, no expansion appliance. You don't have to provide those patients with that. What about a patient who's like this, okay, with crowding of the teeth? Look at the difference in the arch form. It was only done with appliance, with fixed appliances here, okay? So from there to there, okay? Done in 18 months. Look at the difference in the arch form. So people keep talking about, I need a proper arch form. And then somebody's going to say to me later on, but that's because, Geoff, you did non-extraction therapy. What about if I extract teeth? So here we are with this patient here. And have a look. So we've got, and look at the profile to start off with here. So we've got a situation with crowding of the teeth, and I extracted teeth. So I extracted teeth here. And look at the difference. Can you tell the difference with the profile I extracted? Okay. I'm going to show you some other cases soon. But look at the improvement in the arch form from there to there. I extracted teeth, but the arch form is actually still improved. If you know what you're doing, you don't have to get a constriction of the arch form. Okay. What about this patient? This is before treatment. Now you've got to say it's a lot of crowding here. And could you treat this non-extraction? Absolutely. I could fit every tooth in. But I made the decision from a periodontal point of view, I didn't want to procline the teeth any further. And here we are after treatment, okay? And I still got recession. Can you imagine what would have happened if I treated this patient non-extraction, okay? But look at the arch form. The arch form is still the same. It's actually improved a little bit as far as I'm concerned, okay? So before and after. So nobody can tell me I extracted teeth and I destroyed the arch form. What about this patient here, before and after? The arch form's improved, and we can show you this case after case after case. So this patient here, nice profile, okay? And we decided we're going to take out some teeth. So let's have a look what happens with this one. I think she's still got a very nice profile, even though she's had extractions done, okay? And so she's got a really nice bite, nice profile, okay? And so this is where she started. Before we extracted teeth, and she looks a lot better. And the arch forms are better. And now you're going to say to me, but Geoff, I've seen people extract teeth and the profile's wrong. And yes, because if you remember my caveat right at the beginning was do the incorrect use of extraction. So let's talk about that for a second. So in the class 2 malocclusion, the critical path to success, as I teach my students, is a class 1 canine. And that's for numerous reasons, most of it being functional to get a mutually protected occlusion, et cetera, et cetera. Okay, so that's what we want to see, class 1 canine, and then we normally have a good overbite, good overjet, et cetera, et cetera. Okay, now, if you have a class 2 canine, And let's say it's a class 2 Div 2, and we align the teeth. We convert a class 2 Div 2 into class 2 Div 1. So the only way we're not going to get overjet is to get a class 1 canine. And that's a principle that we teach. Okay, whatever we do, if we want no overjet, which is what most patients want, and what you guys want from a restorative point of view and functional occlusion, you need to achieve somehow a class 1 canine. Okay, so we could either extract teeth and we move the teeth back. That's one option. We could do a functional appliance. We could do orthodontic surgery. There's all different options, but our aim for the individual patient is to decide, can we get a class 1 canine and how are we going to do it? Okay. So we could take out the upper fours. Okay. We move the teeth back. Okay. Now, what did I do with this particular patient? Everybody's going to sit here and tell me, you did a functional appliance, Geoff, didn't you? Because look at the jaw, how it's improved before and after. I took out upper first premolars. Okay, everybody, okay. And why? Because she grew. I was dealing with a growing patient. She grew. Okay. And that was the key to this patient. She grew. Would I do it with a functional appliance? Yeah, I wouldn't have a problem with doing that. So I'm going to ask the people in the audience. This is before, this is during treatment, this is after treatment. Did I extract or not extract? And most of you are going to guess because you can't really tell, can you? Okay. And I'm going to tell you Geof Hall's theory about this because I extracted upper fours. Okay. So a patient like this was a class 2 Div 2. I took out upper fours. I brought them back to a class 1 canine. And somebody's going to say to me, but Geoff, if you distalized those teeth, you would have got a better profile. And I'm going to say, excuse the French, because I know it's being recorded, what a load of shit, okay? So, because I don't care whether I extracted, I don't care whether I distalized teeth, I don't care whether I took out upper second molars, I'm still moving the canines back to a class 1. So it'll be the same profile no matter what I do, okay? Now, this is my theory about it. And my theory is, in a class 2 patient, do not extract teeth in the lower arch if you can avoid it. Because if you extract teeth in the lower arch, I've then got to move the lower teeth back further, which means I've got to move the upper teeth back further. All of these cases, I've maintained as much tooth structure in the lower arch, and I just took out teeth in the upper arch, okay? And that's the key. The more tooth structure I've got in the lower arch, that will dictate how far I can bring the upper teeth back. Now, there was this classic 60 Minutes thing with Derek Mahoney and I can't remember the guy's name. And everybody quotes this once again. There's one set of patients. This was a set of twins. And one twin had a functional appliance and the other twin had 4 premolar extractions. And the one who had the 4 premolar extractions had a terrible profile. And what did I say in the beginning? The incorrect use of extractions, because that patient was a class 2 patient. That patient should never have had lower premolar extractions. That's the difference. And I bet you if we just talked about upper premolar extractions, there probably wouldn't have been that much difference in the facial profile, because a functional appliance works in dentoalveolar changes as well. So when you look at it and you do all your superimpositions, there wouldn't be much difference at all. Okay, and this is what people have to understand. Let's get rid of the myths. Let's show you the one case. Let's start talking about 20 or 30 consecutive cases. Let's be far more honest in how we present things, okay? And I can show you case after case. So here we are. I took out teeth. Look, I took out upper teeth. Do you think the arch form improved? I do. And I took out upper teeth, okay? So that was before, that was during treatment, that was after. And I don't believe you can tell whether I took out upper teeth because I didn't take out lower teeth in this case. And that's the key, okay? So that's my ideology in a class 2 case, okay? Once again, here we are. Look at the difference with the profile, before and after. And what did we do? That's before, and we took out upper first premolar teeth. And yet the profile Not a bad result. Could have been a bit better. This is going back. This was done in 2004, this case, okay? So much better occlusion. Profile is still a lot better than what it was before. And we took out upper premolars, okay? So when people say to me, oh, if you take out teeth, you're going to destroy the profile, it's garbage if you know what you're doing. And if you took out 4 premolar teeth, which still happens today, that's wrong in this particular case. So this is what happened. We have mandibular growth. We've got a lot more at our disposal with children than we have with adults because we've got growth on our side. So just want to confirm, the key to success is getting a class 1 canine, because here, this is actually class 2 canine. The canine's here. So if we went ahead and did a non-extraction approach, these upper anterior teeth would come forwards. We would end up with about a 5mm overjet. So here we are. So we take out the upper forwards. How does the profile change in any way whatsoever? The upper incisors have stayed in the same position. And in fact, if we get better torque on the upper incisors, which we can do, the profile could actually be improved in these cases. So let's just do that again, because I think this really demonstrates it. A class 2 division 2 is a perfect case to take out upper fours because the upper incisors won't move. They won't move back at all. Okay? Exo upper fours, lower fives, which we can do, but this would only work if the lower posterior teeth move forwards. We don't want the anterior teeth moving back. That's our problem whenever we take out lower teeth in a class 2 situation. Because once again, this is what we call cartoon odontics, because these teeth don't all move forwards. These other teeth move back. That's the problem, okay? So this was a problem case that we had where we took out upper fours, okay? And the lower anterior teeth proclined too far. So this was a problem case. I thought we could treat this patient without any lower extractions. Profile-wise, that's it. He hasn't changed particularly, but the difference here is that with the lower anterior teeth came too far forwards. So I should have, in retrospect, taken out some lower teeth. Now, the question would have been, should I have taken out lower fives? Probably not, but maybe a lower incisor, just enough to keep the lower teeth back and have a positive overbite overjet, okay? So this is where our clinical decision comes into it, okay? So this was a patient back in 2000 with a severe overjet, and back then we started using the Herbst appliance. We probably could have taken out upper fours as well, but we used a Herbst appliance to bring the lower jaw forwards because they'd gone to 4 other orthodontists and they all said orthomatic surgery. So this was in the very early days of the Herbst appliance. And we ended up with a beautiful result. But have a look at the facial profile that happened with using a functional appliance. See how the upper lip has come back? Okay, because everybody says, hey, if you use a functional appliance, we're going to stimulate the mandibular growth. But you don't just stimulate mandibular growth with a functional appliance. For every force, there's an equal and opposite force. So the mandible's coming forward, okay? The mandible's coming forward, but what else is happening? The maxilla is coming back. We're distalizing these upper teeth, okay? The lower incisors are proclining, and as we talk about in our course, we get these dentoalveolar changes occurring. So what I've done is I've gone from a class 2 to a class 1. The occlusion looks great, okay? But the facial profile, you still have the flattening of the upper lip. So once again, show me 20 consecutive cases, okay? Because I think the profile would have been exactly the same had we taken out upper first premolars. Would have been exactly the same, okay? And then the last part of this lecture is, does extraction therapy reduce the airway? And I know you've had Michael Stubbs lecturing previously, Michael lectures for our Ortho Ed program, and everybody's going to show you these unbelievable pictures of CTs and airways and everything else. But once again, it's a bit of a fallacy, because that's all setting up. How does the airway adapt when you're lying down, which is what we're talking about here. We're talking about when the patient is lying down with CBCTs, et cetera. And all the studies have shown, okay, but basically, if we're looking at the bell curve, don't forget anecdotal cases where somebody's developed sleep apnea, because you'll always get that in these +3 and -3 standard deviations from the mean. You're always going to find those cases that don't fit into the norm, whether it be extraction, non-extraction. And this is why we've got to be careful. What are people presenting and why are they presenting it? Especially people who are presenting stuff because they've got a financial vested interest in something, okay? So we're going to be very, very careful, okay? Because basically what we want is we want to look at this group under the bell curve, because that's what we want to treat in our practice to a 90% standard, okay? And all of the good articles that have been done, okay, there is no evidence that orthodontic premolar extractions directly cause sleep apnea. So there's no evidence whatsoever about that. Okay, changes in airway volume. For every airway measurement examined, except the upper airway, there was no significant difference after orthodontic treatment in both the extraction and non-extraction groups. And people say to me, I just had one client the other day. So do you talk about airways? Well, I get Michael Stubbs to talk about airways, because he talks about it in the proper approach. And everything I do in orthodontics is going to broaden the arch. Every time I put an arch wire in, it's going to broaden the arch. I've just shown you that. So if you believe in airways, that's great, but that's not going to dictate our treatment plan, because we're going to provide some expansion for you, whether we do a line of therapy, we do fixed appliances, et cetera. So I think that's other studies. The airway changes after orthodontic treatment with premolar extraction and maximum anchorage, which means we pull the upper teeth back as much as possible, are mainly morphological changes with the anterior posterior dimension compressed in airway cross sections rather than a decrease in size. So there's no evidence that airways are compromised. I'll play this very quickly, and then we'll
Back on desert island with Adolf Hitler, Attila the Hun, and a lawyer, and you have a gun with only 2 bullets. What do? Shoot the lawyer twice. What do you call 5,000 dead lawyers in the bottom of the ocean? A good start. How can you tell if a lawyer is lying? His lips are moving. Why don't sharks attack lawyers? Professional courtesy. What's the difference between a dead dog in the road and a dead lawyer in the road? There's skid marks in front of the dog. What do you call a lawyer buried up to his neck in sand? Not enough sand. A commandment was given for a dog to speak. The dog replied, not without my lawyer present. If you're trying...
So, for those of you, I have a lot of different lawyers. I must admit, I'm sure, Matt, you're the same. I don't like them, but they just keep charging you left, right, and centre. I wish we could charge every time we spoke to somebody like these lawyers do. So I'm just going to give a very quick plug on our OrthoEd program, because we've had phenomenal response. This year, as I was telling Matt before, I think we were 50% booked up in 2 months. So we're probably going to close off bookings by the end of the year, which is just fantastic. Look, basically, people want an increased knowledge in orthodontics, and we want to reduce the risk of bad outcomes. I believe ortho is just one aspect that you should get involved in your general practice. One, to stay competitive, stop referring patients out, and you get a much better understanding as well in interdisciplinary treatment. You get a much better understanding of occlusion, et cetera, okay? And look, there's nothing wrong with boosting production, and lots of our clients have done that, okay? You can go into our website and you can see all the, we have different modules, we have full mentorship. I pride myself, and I think this lecture was part of that, on teaching you sound orthodontic principles. I'm not into cookbook stuff, okay? Because you're going to go chairside, and cookbooks work in 75% of patients. No different to when you're doing implants or crown and bridge. Hey, you're brighter than the average person. Let's make you think. And trust me, orthodontics is damn easy once somebody teaches you the principles. The problem is my orthodontic colleagues refuse to open the shop, okay? So it's our 2-year programs run over 2 years. We cover the entire gamut of orthodontics from diagnosis all the way through to IDT. Obviously, we cover early treatment, biomechanics, etc., etc. If you go onto our website, you'll see. I think we've got 65 now. 5+ reviews. We've got all these video testimonials, etc., etc. But the reasons you want to do it, I think you want to increase your knowledge. And if you're anything like me, dentistry can get pretty boring. I take my hat off to Brad and the guys at Race, Matt and Brad and the guys at Race, because they're giving you education and they're teaching you stuff to make dentistry more interesting as well and more profitable. And that's what it's all about. So, thank you guys for what you do for the profession. But you need to offer more services to your patient, become more comprehensive. And we've got some people who just do it so they can enjoy more dentistry as well and increase patient loyalty. So that's our website. This is just a small plug. If you want to speak to me, you can go to the website and we can just do a 45-minute call and just discuss your individual requirements. So Race will offer you some credits for lab work, or we will if you sign up. If you tell me that you're part of the race group, then Race will organise you some credits accordingly. Okay, for your lab work, so it becomes a real win-win. So I think I'm on 41 minutes here, Brad. Matt. I keep calling you Brad. My apologies. I went through that pretty quickly, but just to give you a bit of a taste that all these things that are out there are lots of myths out there. And I hope, if nothing else, you go, hey, there was something interesting in there. I can't believe everything I hear from people.
Yeah, look, Geoff, that's fantastic. As usual, the way you simplify these techniques, I can understand why the Orthodontist Institute is booking out so quickly and why you've had so many successful and happy customers. I noticed one of those testimonials there from Jim Rushton, one of the best dentists in the country. He's one of the nicest dentists I've worked with as well. So
Jim is a great guy.
Attracting some quality dentists to your course.
Yep.
I do have a question here, Geoff, if I may. After premolar extraction to retrude anterior teeth to close diastemas, my patient was left with no posterior overjet, causing cheek bite. Do you recommend palatal expansion to eliminate cheek bite, or is there another way?
Okay, that's a really good question. To be honest, it's probably the arch form, the type of arch form that they used or the orthodontist used, okay? Because there's a broader type. I always use and have done for 30 years what they call a Roth 8 Company arch form, which is the broadest of arch forms. Okay, that's what I like to give you that fullness, and that you need to coordinate the upper and the lower arches, so you get that positive overjet. That should not happen. What you could also do though is you could just run some cross arch elastics as well at that particular point. So there's all tricks. And it's a really good point. This is why cookbooks don't work, because you need to understand what's happening. For example, even if you put in a wider arch form, you'll get some tipping occurring. So you need to add some buccal root torque. But that's why you've got to understand biomechanics. That's really the key. Once again, very, very simple to teach.
Yeah. Well, look, and again, phenomenal way that you approach it, Geoff. Even as a dental technician, I seem to really engage in the way you present it and in a way that I can even understand it. So for the doctors that come to your course, it must be phenomenal. I'm a big fan of straightening teeth. As a specialist crown and bridge and implant technician, I know they want to have a perfect platform, even when we're going on to restore with veneers or crowns and bridges. To have that perfect straight canvas or platform makes life as a dental technician beautiful. So yeah, there's so many more ways of growing your practice by learning to do the orthodontic techniques that you're showing. I'm a big fan. For those of you that want to look into it, orthotraining.com.
Sorry, Matt, I'll just go one step further for you, because what you were saying is so true, especially with adults. Now we've got aligner therapy, and you can do so much of this stuff, once again, if you understand the principles with aligners. I know that you guys are introducing your own aligner system, and that's going to be, I think, a great adjunct to them straightening, clients straightening teeth in a simple way pre-restoratively. You know, once again, they've got to understand it, but once they do, this is going to change the way they practice.
Yeah, and look, with your complete aligner planning service, the support that you give people, especially as they embark on a journey, Geoff, it's second to none. Look, Geoff, before I sign off, I don't have any more questions. It's a true reflection of how you present and your information that you present. If I could ask you, for someone that was wanting to get started in aligning teeth, do they sign up with you before they do anything? Do they is there anything you can recommend for the beginner to see if they like what they do before coming your way, or should they just jump straight into the course?
That's a really good question. Personally, I think they just jump into it, okay, because we won't disappoint. But yeah, but there are people out there going, I'm not too sure. Come along to we have a separate aligner course, and that you can get an idea of how we teach as well. And that, I think, the aligner part will stand you in good stead no matter what you're going to be doing with, you know, whatever aligner system that you want to use in the future. So I think that's a great start anyway. The other option, we do a 2-day, and we're doing that in January in Sydney, actually, a Smile Fast course, which used to be a short-term orthodontic course. I'm going to call it now the best introductory course to orthodontics. So it's a 2-day course. Come along to that and say, hey, Geoff, I really like what you're teaching. In fact, we had one person, it was probably a year ago, we did the course, and she was a cousin of one of my clients, and we hadn't heard from her for 6 months, at all. And I phoned up the client, who was a cousin, and said, have we offended her? And because she goes, not at all. She hated orthodontics before she did your course. She now got into the master's degree at the University of Sydney. So I suppose my aim is to give you guys the passion to learn more about orthodontics. And yet, so like Matt says, if you're just not sure, come along to the Smile Fast course. It's very cheap. I think it's about $1,400, and see what you think, because you can actually start doing simple orthodontic alignment cases after that.
Yeah, well, that's fantastic advice. And don't forget, anyone who jumps on the OrthoEd Trainer Institute, they do receive race credits as well of $3,500. It's our way of supporting the OrthoEd, but also supporting our dentists in refining what they're offering and what their capabilities are for each of their patients. Happy patients, happy dentists, happy life. So look, for anyone that wants it, orthotraining.com.au. My name's Matt Race. You can contact me, matt@racedental.com.au. Alternatively, contact customer support at racedental.com.au. And again, thank you all for joining us.
Thanks very much. Thanks, everybody.
Thanks, Geoff. Bye.